Welcome to The Spine Guy. I'm Dr. Brian Seal, a fellowship-trained spine surgeon. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. On our last video, we talked about non-interventional ways to treat SI joint pain. Today, we'll be talking about the next level of invasiveness, which is the use of SI joint injections as well as ablations to treat SI joint dysfunction. So after 4 weeks of anti-inflammatory SI joint belt PT, let's say you still have pain, the next level up in terms of treatment that's non-surgical will be something called an SI joint injection. So we talked about SI joint injection in the prior video, but that's having one of our anesthesia pain guys or physiatrists or interventional radiologists take a needle and put some medicine into the SI joint. Well, first, before you put medicine into the SI joint, which is typically steroid, you need to know if the joint is causing a problem. So number one, before a therapeutic SI joint injection, you really ought to do a diagnostic injection. This injection is usually done with local anesthetic. It's something called bupivacaine, which lasts only 6 to 8 hours, but essentially, the injection doctor will put bupivacaine inside the SI joint. You'll move around, try to trigger the pain. And if you can't trigger the pain and the injection helps you, well, then we know the problem's the SI joint. A successful diagnostic SI joint injection is a 75% reduction in pain after the injection. After you get a positive SI joint injection and you know it's the SI joint, well, then you can move to the therapeutic injection. This can be done even a week after. So the therapeutic injection is done with cortisone, which is a very strong anti-inflammatory. It's steroid. So now, instead of just putting anesthetic in, the injection doctor will put cortisone inside the syringe. Typically, that's something called celestone. It's a very small amount, and it'll go inside the SI joint. Well, the idea is that the cortisone takes inflammation out of the joint and off of the surrounding ligaments. These cortisone injections can take up to 2 weeks to work, so don't worry if it doesn't work right away. There's a few studies that really do support the use of cortisone within the SI joint, and these clinical studies usually take a 2-point reduction in pain as success. So if you have a baseline pain of 7 out of 10, success would be better than 5 out of 10. So it's a little bit less pain. It's not a ton less pain, but it's a little bit less pain. These studies suggest that at 2 weeks, 80% of patients have at least a 2-point reduction in pain, and then at 8 weeks, which is 2 months, 60% of patients have at least a 2-point reduction in pain. Now, there can be steroid-related consequences to putting steroid in the SI joint, and this includes destruction of the soft tissue, this includes osteoporosis, etc. And that's true with putting steroid anywhere in the body. So our national guidelines are no more than 4 steroid injections anywhere in the body within 1 year. I usually tell my patients for the SI joint, if you get a steroid injection and it helps, great, you can have another one separated by 6 to 12 weeks. But I usually don't like my patients getting more than 2 or 3 steroid injections within the SI joint. So let's say the steroid injections help, they don't quite help enough. Now you want to move on to the next invasive level. So the next invasive level after a steroid injection that's inside the joint is something called an RFA, which is radiofrequency ablation, which is the same as rhizotomy. So radiofrequency ablation involves burning the nerves that feed the SI joint. So there's a bunch of nerves around the SI joint that come out of the sacrum. These are called lateral branch nerves, and they supply sensation to the SI joint and the SI joint capsule. Well, obviously, before you burn and ablate the nerves, you have to know that the nerve is causing a problem. So again, the injection doctor this time would take the same bupivacaine, which is a numbing medication, and instead of putting it into the joint, would put it around the lateral branch nerve. So it's called a lateral branch SI joint block. If you block the lateral SI joints and there's benefit, and in this situation, we usually say 50% relief within the first 6 to 8 hours is benefit, then we know that the nerves that are supplying the SI joint are the problem. So if we know that that's the problem, then we can go ahead and burn them or desensitize these nerves. Now, it's not a bad thing to desensitize these nerves. These nerves are not motor nerves. They don't control any function except for pain. There's lots of good studies on radiofrequency ablation for the SI joint, and I'll specify here that there's 2 different types of radiofrequency ablation. There's standard radiofrequency ablation, and then there's something called cooled radiofrequency ablation. The misnomer is that cooled radiofrequency ablation uses ice, which it doesn't. What it does is standard radiofrequency ablation is a probe that goes in, and there is an area of burning of that standard RFA probe. Cooled RFA is a way of circulating fluid around the probe, so that when you do this type of burning of the nerves, you can actually have a larger lesion and more coverage around the SI joint. When we look at all the clinical research studies, it does appear that standard RFA and cooled RFA both work, but cooled RFA tends to have better data than standard RFA. Now, this requires a special RFA probe, so you'll have to ask your anesthesia doctor or your physiatrist whether or not they're using cooled RFA. The two best studies for cooled RFA show that at 3 and 6 months, half of the patients had at least 50% reduction in their pain. And this is compared to 12% of patients in the sham group. So these are really good level 1 studies where they did a probe and they ablated the nerve, and they did a probe and didn't do any ablation. So a true prospective randomized study, and it really showed that half of the patients had 50% reduction in their pain. Now, these peripheral nerves do grow back, so when you have an ablation, this often has to be repeated every 6 months to a year. And you really have to wait 6 months between ablations, and there is no limit to how many ablations you can get in the SI joint, although I think that after 2, 3, 4, 5, you might want to seek other solutions that we'll be talking about in our next video. Now, ablation sounds great, but here's the biggest problem with ablation. Medicare, which is our national insurer for patients over 65, does not cover radiofrequency ablation of the SI joint in particular. I do not know why. The data suggests that it does work. Clinicians know that it works. So we really have to do a better job of advocacy to get Medicare to cover it. Because since Medicare doesn't cover it, Blue Cross, Blue Shield, Cigna, Aetna, they also don't cover it. So it's very likely that if you want a radiofrequency ablation for your SI joint in the United States, it'll end up being a cash pay item. You'll have to talk to your doctor about how much that is and make those arrangements separately. So what if conservative therapy fails? You still have SI joint pain despite the anti-inflammatories, the SI joint belt, SI joint injections, the ablations, etc. What's next? Well, there are things that can be done surgically for SI joint pain, but one thing I would mention is an often overlooked diagnosis where SI joint pain is diagnosed, but the issue isn't the SI joint, is something called cluneal nerve neuropathy. So there are some sensory nerves called the cluneal nerves that come down and that supply different areas of the buttock/SI joint. The middle cluneal nerve actually comes down and it sits right over the SI joint. So many patients have pain over the SI joint, but the issue really isn't the SI joint, it's the cluneal nerve. So cluneal nerve neuropathy can be diagnosed again with an injection. Your injection doctor can take a needle, inject the cluneal nerve, and see if there's relief around the SI joint. We use 50% as success for a cluneal nerve injection. So if you do have 50% reduction in cluneal nerve pain with that injection, you can then get what's called a cluneal nerve ablation, very similar to the SI joint ablation, except you're doing an ablation of the actual cluneal nerve. Now, interestingly, Medicare and other insurance actually do pay for cluneal nerve ablation. Thanks for watching. Hopefully you learned something about the use of injections as well as ablations to treat SI joint pain. In our next video, we'll be talking about some of the surgical ways such as stabilization and fusion for SI joint dysfunction.